guys, Dr. Natalie Azar here with NBC News, coming to you to talk about the COVID-19 pandemic. So I just actually spent 2 days in the hospital, which was super interesting, although I very quickly felt out of the loop in terms of the news cycle. Seeing patients in the hospital and reporting on it without having actually been there feel like two very, very different things. One of the things that I woke up to this morning that seems to be in the news a lot today is all about testing, and particularly serologic testing. Something that we have been talking about for a number of weeks, but it sounds like it's really kind of getting a little bit of momentum now. So just to review what this means for us and for you guys is this. We know the initial round of testing that everybody was talking about was, of course, the swabs, the nose and the mouth or throat swabs. And that was to detect active virus. It was detecting the genetic material of the virus to diagnose acute infection. What we're talking about now, we're still talking about that, but what we're also talking about now are things that are called the serologic tests. And that specifically has to do with testing whether or not your body has been exposed to the virus and has mounted an immune response. And there are two different things that we actually look for, something that's called an IgM and something that's called an IgG. And typically, after you've been exposed to an infection, your body will make an IgM first. And then after that, the IgM goes away. And then your body makes something called an IgG, which can stay positive for one's lifetime in certain conditions. And it can also certainly drop down after a number of years if your immunity wanes. Now, it's been thought since this outbreak started that once you were exposed and had infection with COVID-19, that you would remain immune for some period of time after. What we don't know yet is just how long that immunity lasts, and if in fact infection does confer immunity. Something that will help us determine that is actually to be able to measure these particular antibody levels. So as I see, there is a lot of debate or a lot of concern about whether or not these antibody tests have been validated. So the big issue now, again, is whether or not these antibody tests or these serologic tests can be scaled up to match the demand. So I think Dr. Fauci made a mention about the fact that by next week, we're going to have some testing. But I think everybody's concern is, again, this interplay that really is needed between the government and the private sector just to deal with the magnitude of the demand of these tests, because it's not only important for people to know whether or not they had the infection, to know whether or not they can go back into the workforce, and particularly for healthcare workers, if they can feel less concerned about their own safety while they're working, but it's also really important for surveillance. As we've talked about a lot, we just still don't really know what the true penetrance of this infection is in our population. So it would definitely give us a lot of information, and I think it would give us a lot of useful tools moving forward as we get to the point where, hopefully people are able to start, re-entering their lives and, just in terms of all the economic fallout from all of this. So let's see if we have any questions coming up about that or anything else. I mentioned at the beginning of this Facebook Live that I just spent 2 days on the wards in the hospital taking care of COVID patients, which was an unbelievably incredible experience. Very, very rewarding to be just practicing medicine again in that capacity. It was unbelievable to see the amount of coordination and collaboration amongst all of my colleagues, and that includes the nurses and the PAs and the respiratory therapists. All of us, I should say, pretty much all of us were reassigned. So I was working with nurses who normally do transplant, and I was working two partners. One was a gynecologist and one was a primary care physician. And our leader was a hepatologist, a liver specialist. And, we were all taking care of these patients, many of whom were quite sick. and a couple of whom were very, very stable. And as I said in one social media post, that for the patients who were stable enough, they certainly felt a little restless, I would say, maybe a little bit bored. And I think everybody felt very, very isolated. I know that was talked about a lot in the news, and that was definitely something that I witnessed as well. We were not, every time we went into a patient room, we had to don our PPE, which, takes time. And between patients, we had to change our PPE. So, we had to minimize the number of times that we went into the bedside. And, I know that was really hard for the patients. The day can get very, very long. No, I'm not I am not in quarantine. The recommendation, if you've been, if you're symptomatic, obviously I would be in quarantine, but no, I am not. Let's see. How long do we have to stay? Restaurants, fast rooms, and movie theaters. Yeah, that's a big question. I don't know that we go back to that kind of normalcy for quite some time, unfortunately, just with the crowding. And as I said at the beginning of this, one of the biggest issues, of course, is the antibody testing and how important that's going to be to give us a little bit of a better indication of, number one, who was infected in the past, and number two, probably more importantly, if having antibodies detectable in the blood actually does indicate that you have immunity. The tests are, I guess some of the first tests that were rolled out, especially in the UK, were not found to be reliable. And I think that might have something to do with the fact that there has been such an urgency to get these tests up and running. But I think most people think that the only thing worse than not having a test is having a test that's not validated and not good. There's still, unfortunately, as many tests as we've done, if you're in the community and symptomatic, but don't have a lot of significant risk factors, it's not likely that you're going to get tested. Unfortunately, it's still being reserved for healthcare workers and for those folks who are hospitalized. And I know in the outpatient setting, we are doing some testing in people who are at significant risk, for example, transplant recipients and people with compromised immune systems and things like that. So that's an interesting question about the steroids. We just had a case in the hospital of a patient who was declining, and she did get IV steroids and did very, very well. But I think it's still a little bit of a debate as to who is the best candidate for steroids and when to give it. There's two concerns with steroid. One, or I should say there's two issues with using steroids. One is that it can suppress the immune system further, and that's the last thing you'd want to do in the face or in the setting of infection. But on the other hand, we know that one of the things that can be incredibly dangerous, and the thing that very often kills the patients, is this really hyperactive and robust immune response called the cytokine storm. And the issue is whether or not steroids could have a benefit there. Well, somebody asked if they should pay for an antibody test. I think before you spend any money on this antibody test, you would want to make sure that it's a test that has been validated, because the last thing you'd want to do is spend money on something and then find out that it wasn't a good test all along. All right, thanks, guys. I didn't have the hearts.